Welcome to the second part of the assessment video. Here we're going to talk about SFMA, which means Selective Functional Movement Assessment. This was developed by Cook and his colleagues. They've done a great job of figuring out what all the movements that have to be tested and breaking them into 4 primary patterns or primary diagnosis kind of criteria, where it kind of gives you clues where you need to assess or break out the pattern, or where you should look closely, or where you should start your treatment. I'll go in detail as we move along. I want to give you what those 4 things are before I show you what are the 7 cardinal movements Cook and his colleagues came up with that you have to test. So the first is functional, non-painful pattern. That is a pattern where the person is able to control through the full range of motion with no pain. The next is a functional, painful pattern, where the patient is able to complete the motion but complains of pain, either end, middle, or through the range of motion or the end range of motion. They do have pain. When I say pain, it's not tightness. When they say it's tight, it feels weird, it's not comfortable, it's not pain. They have to be like, oh, I can do it, but it hurts really bad. So that's pain. The third pattern is a dysfunctional, painful pattern, where it looks, they cannot complete the range of motion. It looks like it's compensating a lot. It looks awkward. It's not smooth. It's not the right way to move, but they also have pain. So these are the main problems they come to you with. Oh, I can't touch behind my shoulder. It hurts really bad, and they're doing everything to get there. That will be considered a dysfunctional and a painful pattern. So the last thing, the most important one in the SFMA, is the dysfunctional, non-painful pattern. These are the patterns they don't tell you there are problems with. But when you look, the motion either is not smooth, not efficient, and is not right as part of the SFMA assessment. So let's say they're not able to touch their chin to the chest, but they say it's not painful, but it was still considered a dysfunctional pattern, but it is not painful. So all the movements have to be categorized into these 4 parts. So we'll go through the 7 cardinal movements that SFMA has designed to figure out where you have to look closely. If there is a dysfunctional, non-painful pattern, that's what you treat first, so that the dysfunctional painful pattern or the functional painful pattern falls in place. They give a lot of importance to 2 components: identifying mobility restrictions or motor control restrictions. We will see what they are in the subsequent part of this assessment. So I want to introduce you to the 7 cardinal movements that you have to know to assess and categorize under these 4 headings, which is your functional painful pattern, functional non-painful pattern, dysfunctional painful pattern, and the dysfunctional non-painful pattern. Danielle, would you please come this way? I want to show you the first pattern, which is the cervical movement. In this, the question you have to ask or tell, if it's your patient, could you try to touch your chin to your chest? So you want to see, are they smooth? Are they able to finish the range of motion? In Danielle, as you can see, there's a lot of space. She's not able to touch her chin to her chest, which would be considered a problem in the SFMA. So I asked her, is there pain with that motion?
A little bit.
So she's a little bit, not painful. So I would categorize that as dysfunction, definitely, as because she could not complete the motion. And I would consider it as non-painful because she didn't say a whole lot of pain, a little tightness kind of thing, right?
Mm-hmm.
Okay. So the next movement pattern is to look up all the way, which would be cervical extension. You ask the patient, can you look up all the way? Are they able to stay parallel to the floor? Are they able to clear? Is the chin going up? So for her, I would ask her, is there pain with that?
No.
So if there's no pain, this will be considered a functional, non-painful pattern. So this is something I can clear. Extension is not a problem, not going to focus. Flexion is something I need to address in the future or later for my treatment. So the next one I would ask her, are you able to touch your chin to the mid-clavicle area on the other side? So the rotational pattern, this will be flexion and rotation. So she's not able to bring her chin to my finger at the mid-clavicle area. So I'd ask her if there's pain with that.
Yeah.
So there, she said there is pain. So I would consider this dysfunctional and painful pattern. So this is something she'll come to me for a problem. She'll say, I'm having trouble with this. So I'd ask the same thing on the other side. So is she able to touch her chin? Same thing. She's not able to. So this is definitely dysfunction, but I need to know, is it painful or non-painful?
Painful.
So both sides is painful. Only the flexion was non-painful. So which means something I would address the flexion first, which is non-painful, less irritable, and you will see the change. The dysfunctional painful patterns will get better. But we'll go through that when we go to treatment. So the next pattern I want to assess is the upper extremity movement patterns. So if you could turn and face that way. The first one is where I want to see actually turn and face that way. I would ask the patient to use their right arm and touch the spine of their scapula behind their head. Are they able to make it? That's excellent. So she was able to make that well. I would also look, is she able to stay her head straight or is she compensating? But from this view, she made it well. Is there any pain with that?
Feel stretch.
Stretch is not pain. So I would consider this functional and non-painful. I would ask her to do the same thing on the other side to look, what are the differences? Is she able to make it? Perfect, no problem. So this would be considered functional, non-painful if there's no pain to it. So the second pattern of the upper extremity is, are they able to go behind their back with the right arm, touch the inferior angle of the scapula? If they can make it there, that's good. Even though you see a lot of winging of the scapula, but it's fine. If there's no pain, that will be considered functional, non-painful. Same thing on the other side. She looks perfect. She was able to make. So this range of motion is not going to cause her problems because this is functional and non-painful. And moving on is multi-segmental flexion. Would you turn and face that way to your right? So when you're looking at multi-segmental flexion, you're going to ask the patient in all these tests except for the functional squat, you want the patient to keep their feet together. For validity, you want all the patients to be tested in the same position. When you retest it, you do the same thing. So that way you're not changing variables. So you would ask them, they can raise their arms up for momentum, but the goal is for them to see if they can touch their toes. That is multi-segmental flexion. Daniel, would you please go ahead and touch your toes? What I'm looking to see is she able to flex her neck and comfortably go down all the way? Is she able to touch her toes? Is she able to bring her weight off and shift her hips backward? Is this staying parallel? Is this smooth motion? As you can see, she's not able to keep her head down. She feels like she has struggle. Is there pain with that?
Yes.
So this will be a functional and painful. But as you can see, she did not touch all the way, so I have to call that a dysfunctional. But if she would have touched the toes, then I would have said functional painful. But as she did not touch her toes, I'll consider this as a dysfunctional painful pattern. Would I treat this first? No, there's a pattern. We'll address that later. So the next component is extension, which is called multi-segmental extension. We're asked, can you raise both your arms up all the way and bend back all the way as far as you can? I might stay back to support her. As you can see, she just barely went there. The goal is for her to be able to be parallel with her scapula to be parallel. So if I support her, she's coming there. Little shaking, quivering is normal, but I would ask, is there pain with that?
No.
So I would consider that dysfunctional, non-painful pattern. Remember, SFMA keeps the fascial lines and fascial network and connective tissue in mind. So which means if I work the front of her body with my techniques, tools, whatever, in subsequent lectures you'll see for treatment, this could affect, this is a dysfunctional, non-painful pattern because she's not able to clear, but there was no pain. I would address this first, and then I will see her flexion would improve. So the next pattern is multi-segmental rotation. Daniel, would you keep both your hands up to there, and first turn that way as far as you can. What I'm looking to see is her shoulders coming parallel. Is she able to turn her head? Is the hip rotating? Is the pelvis rotating enough? That should be at least 30 degrees. As you can see, she's struggling to turn a little bit to the right. Is there pain with that?
No.
There's no pain, but she's not fully turning. So that'll be dysfunctional, non-painful. We would do the same thing on the other side. Is she able to turn to the left all the way? Is she able to clear and maintain parallel? It looks a little smoother even to her. Does it feel easier to turn to the left? As you can see, she's able to turn more on the hips and bring her pelvis and not a whole lot of curves here and not compensating too much for left rotation. So this will be considered functional and non-painful pattern. That is what we want to achieve at the end of the day. And the next one would be, the most important one I would say, is single leg standing for balance testing, because this testing also incorporates balance as part of its assessment. So I would ask her, would you be able to stand on your left leg, lift your right knee up to my hand? We want it to be parallel. And see if she can hold that position for 10 seconds. So I'll count 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. That'll be no problem with this testing. There's no dysfunctional pattern. If she loses the height, it will be considered dysfunctional pattern. Same thing on the other side. We don't have to go through. It will be considered dysfunction. But the key to add to this is, can you lift your right knee up all the way? In same position, they have to do their eyes closed. Close your eyes and see if she can maintain 10 seconds. So 10, 9, 8, 7, 6, 5. As you can see, she was not able to. That tells us we might have to work on kinesthetic sense, vestibular sense, all the components that improve her balance. So she might have issues with balance. That also indicates problem with her cervical spine. That's why she has issues with balance. Because if the cervical spine is the one that has most muscle spindles, at least about 37 muscle spindles in their neck compared to glutes, which only have 7. So that shows how efficient her neck has to be to maintain her balance. So that way we can tell, okay, balance is an issue because cervical spine is also probably playing a part in it. So the last one, this is the only place where you keep your feet apart, shoulder width apart, to do a squat. What I'm looking to see is she able to raise both her arms up, and is she able to go all the way down? Is she able to clear parallel? Is she able to go down all the way to the floor? Do a full squat. Come down all the way. What am I looking to see here? Is she able to keep her head relaxed? Is she able to maintain at least 160 degrees of flexion in her shoulders? Is she able to keep her knees pointing straight? Is she turning her feet to the side? These are all the things which I'm going to look for. She looks pretty good for a squat, so that's something I will not be worried at this point. I'll still consider a little bit dysfunctional, but still non-painful. Something I would work on if her knees are going inward too much. So that completes the 7 cardinal movements and categorizing each movement into the testing pattern. So just off note, for treatment, you always treat the dysfunctional non-painful pattern before you address the functional painful or dysfunctional painful pattern. This is a great holistic way of assessing the whole body to get an idea. The patient could come with neck pain, shoulder pain, knee pain, ankle pain. If you're able to do everything well, if you're able to correct and then get to a point where everything is functional and non-painful, that's ideal. But also again, if there's a problem, you have to break it down. So as I mentioned before too, 2 things SFMA stresses: is it a mobility problem or a motor control problem? And I will give you examples of it. So let's say if somebody's able to raise their arm up all the way, but only till here. They have a mobility restriction, probably, we don't know. But if I'm able to passively do the same motion, and they're able to do that well, then that is not a mobility problem. If the problem is a mobility restriction, it would be same active and passive. And we will give you a demo of what that means in laying positions. Let's pause for a moment. When we talked about how do we identify a mobility restriction, or is it a true mobility problem or just a motor control problem, which means a true mobility problem is present active, passive, same way. So if somebody's not able to accomplish a task actively and I go back to them and do it passively, if I'm able to do it easily and there's no restriction, then that is not a mobility problem. It's probably a motor control problem. As you've seen for Danielle, she definitely had dysfunctional, painful patterns coming to the right clavicle or the left clavicle. So I'm going to test and see if I do this movement passively, is she able to do it? So I'm going to do a passive testing where she's not going to help me. I'm going to test and see, am I able to touch her chin to her chest? So if it was a true mobility problem, I won't be able to go because something is going to be so tight or rigid, won't allow me. So then I will know it's a mobility problem. As you can see, I can easily go and touch her clavicle on the right, way better when she did it in standing. Sometimes even offloading can give you a lot of cues. So if she's able to do the same thing in laying position, I will test and see, can you touch your chin to the clavicle on the right? much better, much easier. Does she have a mobility problem? Absolutely not, because she's able to do it, but when she's loaded, when she's sitting or standing, the nervous system doesn't think she's capable. So that is definitely either a motor control problem or a mixed problem. But for her, I would say it's just motor control problem. The nervous system is not allowing her to do the motion. Because can you touch the clavicle on the left side? So as you can see, she's able to do it. So it means the nervous system has an influence on her. It's saying, you probably are not capable if you do it in standing. You might fall. So balance and mobility and nervous system feedback is saying she's not capable. So that's how I can break it down and start treating. Because for her, I need to train not mobility. I'm not going to work on stretching or improving the flexibility of the spine, because I know there is flexibility. When I looked, I would say, oh, restricted range of motion, I'm going to go stretch. It's absolutely ridiculous to do that because she doesn't have that problem. But instead, I will check something called motor control. If I support the other structures, because as you can see, just by being supine, she feels supported. She did a much better job. But if I added more feedback to the system, let's say this can be done with a band or a hand just to test. But I could ask her to gently push down or pull up. I will ask her to push down gently into my hand. That will give us a little control from the abs and the core. And then ask her to do the same thing, touch. And ask her, is it a little smoother for you if it's easier to you?
Yeah.
So that means a motor control has a part to play. So now I train her to do it by giving a little feedback. She will push down or activate the other structures of her body to support the system, to give the confidence she can do well. So then again, we test it by training. If she's able to do it actively in standing, then I've made a change. So that completes identifying mobility and motor control deficits. You can see that in the leg. Let's say if somebody's not able to touch their toes. Ask them to bring their knees to their chest. Could you bring both your knees to your chest? So look at her. She's got great flexibility. She can do very well. Can you put your feet down? Can you come up and touch your toes here? For that, I would say actively she could not touch her toes, and also in an offloaded position she has trouble. But if I take her passively, that would be a mobility restriction. So which you can identify, there's some mobility restrictions in her spines because she cannot do it in a loaded position, offloaded position, not actively nor passively. So that will be a mobility restriction. But if she was able to touch her toes fine and had no problems, but she could not in standing, then I would have to say there's probably a motor control problem. Some of them have mixed problems, a motor control and a mobility problem. But treat the mobility deficits first before you treat the motor control problems if they have. But the key is to identify if they have a mobility problem. But you see poor range of motion, not able to move, no stretching. There's no need for it. It's not a mobility restriction if they don't have it. So that concludes our SFMA assessment. This should give you a brief idea of how to move forward and do the assessment using the SFMA method. If you like this videos, any of the assessment videos, I would encourage you to subscribe to my channel and please post your comments. Thank you and have a great day.